Hello, I'm Matthew Gavidia. Today in the MGH Life Sciences Medical World News, the Center for Biosimilars is pleased to welcome Ryan Cox, Vice President of the Access Experience Team at PRECISIONvalue. Can you just introduce yourself and tell us a little bit about your role at PRECISIONvalue?
Hi, Matthew. Yeah, thank you. PRECISIONvalue is a market access marketing agency. We work with pharmaceutical manufacturers to help them launch and place their medications with payer decision makers, really bringing our experience of helping drug launches and provider value perceptions to their products, helping them to maximize their commercial success. Part of that, as you noted, I'm part of a team called the Access Experience Team. We are something that's distinct in this industry, in that we actually are a team of 20 prior, more than 20 actually, prior key decision makers from payers, PBMs, integrated delivery networks, health systems, specialty pharmacy, and the like. And we bring our expertise into helping to craft those messages and make sure that they resonate and are meaningful to those decision makers, whether it be at a health plan, a PBM, a specialty pharmacy, or an IDN. I actually joined PRECISIONvalue in January of 2019, so I've been here going on 2 years. Prior to that, I spent about 20 years in managed care, most recently with Highmark Blue Cross Blue Shield in Pittsburgh, Pennsylvania, where I was the director of the specialty pharmacy strategies. And prior to that role, I was the director of clinical pharmacy, holding decisions on P&T, formulary utilization management, managing a prior authorization center. Before Highmark, I had leadership roles at Humana, CareSource, which is managed Medicaid in Ohio, and Anthem and WellPoint, which is really where I got my start. I am a pharmacist by training. I got my start in retail pharmacy. I did that for about 10 years before moving into managed care.
And to clarify for our audience, are you a consultant to payers or a consultant to employers?
Actually, to neither. We are a consultant to pharmaceutical manufacturers, so we work directly with them. We do help bridge and bring together the opinions and thoughts of not only ourselves and our experience, but also through a proprietary network of decision makers that we're able to tap into to either do rapid pulse questionnaires, do some panelists, whether they're blinded or unblinded, and bring those together with that. So we act more as a consultant to the pharmaceutical manufacturers.
What has been the problem with biosimilar uptake as employers see it, and have they been getting the support they want from payers?
Yeah, I think there's a few things to kind of break down there, and I wish it was a simple answer and say here's how we would solve that. Obviously, over the last 10 years since the biosimilar pathway was developed, there have been some savings. Obviously, I think we approached close to $5 billion since 2010 as of the end of last year, but about half of that occurred last year. So we are seeing some increased uptake. Some of the challenges I think that we're running into, one is a lack of interchangeability. I think everybody sees the savings that were generated from small molecule traditional generics when they launched, whether that would be from the Lipitor, when atorvastatin came out, et cetera. They have interchangeability. They have a lot of competition, and there's also some regulations at the state level that requires the use of generics first. Biosimilars are a little different. One is the science is a little newer than what we saw in the others, so understanding, getting that comfort level. That lends into the next thing is the education. Is the lack of interchangeability, are they safe? Are they effective? From the science that we understand that pathway, yes, they are. But having providers and the patients themselves have that level of comfort, I think that is still in the process, and that needs to continue to grow. From the employer perspective, I think understanding that what the total net cost is of these products is probably also a challenge for them. Looking at just from that gross, the AWP or the WAC price of these things, that may look like the biosimilar is actually less expensive, but when you look at the net costs after rebates that are typically passed almost all onto the employer, or back to the employer, I should say, that net cost of the originator may actually be less expensive for them. So helping them to understand and have some visibility, I think the transparency within that is probably still something that needs to occur to help them to understand that.
Can you discuss some examples of how large employers have been taking the initiative on biosimilars?
With respect to some large employers. So obviously there was some information that came out earlier in this year that discussed CalPERS and Costco and Disney and some of their approaches. And they're looking at the opportunity to look at what they're paying for these products. I think that what they're doing is the right thing. They need to be able to distinguish and maybe look at dissociating rebate to looking at just the cost of the products themselves, and looking to push and embrace biosimilars. Right now what we've seen is they're focusing in on infliximab or maybe infliximab and filgrastim, but looking at using or requiring new starts to start on the biosimilar, I think is a good way to start that transition. And then looking at that, I think Disney's model, and they refer to it as Disneyfying it. I think they installed an infusion clinic in Epcot that allows their employees to actually go there. So that gives them a sense of control, also convenience for their employees. But if they have either the provider or the physician on site, then obviously they can actually direct that therapy a little bit more effectively. So I think these are good things. It still doesn't address some of the issues as we're talking about the total net cost of the product. I think that still needs to be decided, but again, looking at just gross cost difference, I think that they will see some expected savings just if you're looking at it through that lens.
How meaningful is this dynamic in terms of how it may require a shift in priorities at the payer or PBM level now and as you foresee it in the future?
Yeah, I think from the payer perspective, looking at as I talk to the difference between that gross and the net cost at the end of the day, infliximab, Remicade specifically, was a highly utilized, still is, and it's also a rebatable drug. So those rebates are used for various things. They're passed back in some portion to the plan, and that could be the employer in instances. So those things have to be accounted for. And looking at that difference in the gross versus the net cost, at the end of the day, their priority is to make sure that they're getting the lowest net cost product on there. However, from a health plan payer perspective, you don't want to be the last one that's not out there embracing the biosimilar. So I think prioritizing that is really going to be something that we're going to see in the future. Some differences that I've seen, and this is more of a recent trend, but with biosimilars now available for oncology products, so Herceptin, Avastin, Rituxan, we've already started to see from utilization perspective a shift towards increased use of biosimilars. Difference being here is those products are more of, I'm going to use the term acute. They're used in a short term in a defined window versus a Remicade that tends to be used over the course of somebody's life because they have a chronic immune disease. So there are some differences there, but we have seen that there has been that shift, and it can happen. So providers are in the oncology space starting to embrace that. I think the next big challenge and the big thing to watch for is biosimilars for Humira. So 2023 is we will see the launch of several biosimilars, and at last count, I think it was 6 or 7. Amgen is first. I think Merck Samsung is second. BI, Boehringer Ingelheim, will be third, with several other products following on during that 12-month. Multiple biosimilars. There was some talk about potentially one of those first 3, maybe all 3 going after interchangeability. I think that will be a game changer if there is interchangeability approved for that. But that definitely is something that I think will help to shift that.
What policy or cultural shifts might you be suggesting to payers to ensure a seat at the table during this transition?
I think, as I've noted, that interchangeability is something that is really going to help with that transition. From a payer perspective, as they are looking at non-interchangeable products, is you're just increasing the competition within a space and they're going to be looking at managing these very much like they've been managing specialty drugs all along. It's something that a doctor would have to write a new prescription for. So whether I was switching from, I'll go back to some of those old small molecule traditionals, switching from Lipitor to Crestor or Crestor to Zocor would require a new one, but moving from Lipitor to atorvastatin didn't require a new prescription. In fact, that is something that could be facilitated at the pharmacy itself. From a payer perspective, is learning how to balance and look at, as opposed to just being driven by rebates. I think that's something that does need to change. There's been some talk on, earlier, I should say later in 2019, is trying to reduce or remove rebates. I think that is something that is driving this down to that low net cost. That's something to consider, is where does that additional revenue come from once and if rebates do go away. And I think that's really what's driving the continued use of the originator product in this case.